way we've been thinking about genetic data with phenotype data in population health studies is a fashion that as we move to very large population cohorts, the scale of data sets that we'll be looking at is on the order of millions of individuals, tens of thousands of phenotypes, and as whole genome sequencing starts rolling out, tens of millions of genetic variants. Now, managing that data becomes quite challenging. So one of the motivations for us in terms of as methods developers is to think of methods that may be able to handle that type of data. So when you are faced with this problem, one of the things that we've been thinking about is how do we go from this big data world to a small data world? In most genetic studies, what we see being reported and published are summary statistics, such as effect size estimates and uncertainty estimates from linear regression or logistic regression. And that reduces the dimensionality of the problem quite a bit. So to that end, what we've been developing are methods that work on top of summary level data. So that in the moment in time when we do have access to summary level data from GWAS catalog and these other large-scale population biobanks, we don't have to worry about the dimension that's brought in by the number of individuals that are included in these studies. To that end, in the lab, we've started developing a browser called the Global Biobank Engine. This is inspired by the EXACT browser and the inflammatory bowel disease browser at the Broad. And one of the first studies where we've started putting some of these methods into action is the UK Biobank data set, where data from over 500,000 individuals was made available to researchers across the world. As Mark alluded to, one of my keen interests in thinking about using genetics, and one of the things that's kept me in the field of human genetics, is to think about what opportunities exist for decreasing the risk for human diseases. One such opportunity that exists from genetic data is the identification of particularly strong-acting loss-of-function alleles that confer protection to disease. And using the UK Biobank data, along with other data sets, we were able to identify some of those leads. And furthermore, one of the activities that you are starting to see is the scaling up of these studies as they move from directly genotype data to exome sequencing and whole genome sequencing studies. And we're developing methods for that moment in time when those data sets, at least the summary level data, are made available. Now, the second component that I do want to share with you in terms of ways we're thinking about genetic data is in thinking of genetic risk. Here's a diagram where you see an individual identified as having high genetic risk according to a polygenic risk score, and another individual that may have lower risk according to that genetic risk score. One of the recent studies that was published from Sekathirasan's lab showed that in the context of genetic risk to human diseases, lifestyle can be an extremely effective modification of that disease risk. For example, in the context of coronary heart disease, individuals that have high genetic risk to coronary heart disease, individuals that have a good lifestyle, then be able to modify that genetic risk that's attributed to them. Similarly, if you do have low genetic risk and you have poor lifestyle behaviors, that can still drive up your disease risk quite a bit. So to that end, it really is one of the motivating factors for us in terms of developing methods for thinking about how we can bring in our estimates of effect sizes across the genetic variants in the genome and how that contributes to disease predisposition. So in terms of thinking about the future and where some of our research is going, one of the things that we're particularly interested in is thinking about how we can make the connection between common genetic variants, rare genetic variants, common diseases, and rare diseases. One of the properties we're starting to see from these large-scale population efforts is that you have a hybrid of mutations that contribute to rare diseases, but that can also contribute to common diseases. For example, the MODY genes have been identified as genes that contain mutations that contribute risk to mature onset diabetes of the young. In addition, they've also been identified to contribute to type 2 diabetes risk or adult onset type 2 diabetes risk. The second phase, in terms of the future activities that we're thinking about, is how we can use some of these genetic risk scores in addition to identifying these rare, strong-acting mutations in terms of prediction and prevention, as well as proposing opportunities and strategies for precise diagnostics and treatment. Lastly, in terms of activities that are coming online based on these large-scale population cohorts, they're now starting to collect environmental data. And one of the activities that we're starting to see is the opportunity to address how is it that the genome and the environment interact with each other, and whether or not the environment can modify disease risk due to its interaction with the genome. In the course of our research, we're thinking about this in the context of asthma, in the context of type 2 diabetes, and in the context of myocardial infarction. So with that, I'd like to thank all of you for your attention and appreciate it. Thank you.